So beyond that, which is I would have called the back office piece, there was a front office piece too. And Rich, often that front office piece had a lot to do with the clinical pathway itself. How are these patients going to be treated? And I'm curious because, and again, you're in an institutional setting but not every patient can go in a research protocol. And then are those patients all one-off? Or are those patients not on protocol, still on a protocol or a pathway? It's just the other. It becomes the OCM related or practice pathway for those not eligible for a trial.
Well, I think obviously I think the emphasis upon guideline-based management is paramount, and that's another emphasis of this program.
Yeah, but is guideline NCCN, and it can be level 1 or level 3, and if it's in NCCN, it flies? Or is it much more restrictive than that?
No. For us, so I don't feel constrained in any way in terms of management from the program. So although guidelines are emphasized, we do have a lot of leeway in how we manage patients, whether it's part of standard of care or on clinical trials. From my perspective, and something I'd be interested to hear from the rest of the panelists is what is the impact of this program upon clinical trials? Because again, from my standpoint, clinical trials play such a major role in the care of our patients.
So it's a good question. So Kavita, we do have performance metrics. We've had 2 reports now. We had the initial 2-year benchmark report, and then the subsequent report in December of 2018.
And there's 3 actually.
Oh, the third is out? The third is out.
Yeah, we did about a month ago.
So what have we learned so far?
So we've learned that drugs are more expensive.
More expensive than we thought?
Yeah, I would. So yes and no. I mean, right. I don't think anybody on this panel needs to be educated that drugs are more expensive, but I think that something that has been surprising is that the rate of increase of Part D drugs, especially cancer drugs, obviously, are at a higher clip rate than Part B as in boy drugs. So everybody keeps talking about kind of physician-infused, the old adage of chemotherapy with someone sitting in a chair for hours is really with checkpoint inhibitors. That, I mean, we're seeing like a dramatic change in just the advent of oral kind of immunotherapies that are readily convenient and accessible to the patient in all kinds of cancers. And that's a big kind of news flash from the OCM results.
So let me put some numbers on what Kavita just said, which are really startling. If you look at the increase since early 2012, if you look at the increase in costs and prices, Part B, 26%. Part D, 280%. So what you see is, if you look at the components that affect the OCM in terms of drugs, if you look at service costs and everything else like that, they've absolutely stayed roughly the same. They've increased a little bit, but what's really increased is the Part D thing. And I want to go back to something that Rich said, because he asked about clinical trials, but before that you started talking about with pathways. The interesting thing in this is if you look at the spectrum of practices, and so I get to look at a large number of practices, they're all implementing it differently. So they're implementing it differently, especially in terms of pathways, because they haven't been handed like an insurer would hand them a pathway and say, you must follow that. They've implemented their own pathways. And I think the practices that have been successful also have tried to sort of narrow down those pathways, not guidelines, but basically pathways.
So you're saying that pathway is more restrictive than the guideline?
Yeah, absolutely. Pathway more restricted than the guideline, but what I'm saying, that's provider driven. That's not, the government handing down and say, you shall follow this pathway.
Right. But so Kavita, as kind of a policy expert and somebody who maybe also, by virtue of your background, maybe sees more population health aspects here, you would think if everyone is doing their own experiment, in a federated model, and then you see, but wouldn't there be one that would be better? Shouldn't at some point come out of this as there's a best way? Or there's 3 best ways? NCCN finally got to preferred regimen, so you don't have 20 for adjuvant breast. You've got 3 that are preferred. Is there an attempt to try to get to that point from this?
Attempt by who? So attempt by the government? Probably not, because I just don't think any administration would like to say that the headline could write itself that the government is forcing cancer doctors to only prescribe certain medications, and that would be a disaster. But to your point I actually think other payers are paying very close attention, and certainly large national payers have already, as Ted mentioned, said, here's your prescribed pathway, you must go use it. But we're now seeing even more kind of like emphasis on, how do we manage the pharmaceuticals and third parties that are quite honestly so much better at doing it than any doctors I know and any insurers I know. So we're seeing enough kind of interest in that space. And clinical trials, I would say a deep flaw of this program is that, so you can be in OCM, your patient can be in OCM, as you know, and be on a clinical trial as long as the, quote, drug, the part B or D cancer drug that triggers the episode is not part of the trial. It can't be trial, it can't be drug XG123. It has to be, pembrolizumab or something. I'm just making that up. So the flaw in this is that there is still a reluctance, because there is a way to do it from a policy standpoint to incorporate people who actually are on a drug that's part of the trial. But I think that that was one of the areas that was kind of said, that's not a priority right now. And I think that's a mistake, because I think more and more doctors, and I would say the Columbias of the world, the Hopkins of the world, we know that like cancer predominantly goes on in the community, and community doctors are leading trials. So we need to find a way to make all of this work.